Dr. Batul Kaj-Carbaidwala is a pediatric hepatologist and a gastroenterologist at Lurie Children's in Northwestern Chicago. She is a proud mom of a 5-year-old that we're going to see in a red dress running around, and also a proud wife of Shahzad Carbaidwala, who will be running the fitness session and is doing the Fitness Over 50 session right now. Our next panelist is Dr. Nafisa Mogri. She's a pediatric endocrinologist at Children's Health, UT Southwestern Dallas. Her special interest is in pediatric bone disease. She's the medical director of the Metabolic Bone Program. She is a multitasking wife and mother, and someone who makes sure that her kids are getting enough daily calcium. So if anyone knows how to get 4 servings of calcium by the end of the day, please find her after the talk. Finally, Dr. Adnan Rafiq is an internal medicine physician that currently resides in Houston with his beautiful family, 4 kids, although the mom, I'm going to give her most of the credit, ages of 17 to 8 years, and his mom. As the saying goes, everything is big in Texas, and so is family. He's been practicing medicine since 2009 and currently has an independent internal medicine practice where he focuses on diabetes, cardiovascular disease, hormone replacement therapy, and weight management. I sincerely welcome the 3 of you for giving us your time and your expertise, and thank you very much.
Thank you, Alifia Ben, for that kind introduction, and also for all of the really hard work that has gone into the background of making this talk happen and the conceptualization of the topics. I'm Batul. Pehla to aap sagla no shukar karu chu for listening to us and staying for our session. We hope to put the fear of obesity into your hearts today, especially in the children. So let's get started. Pehla to aaj ke the pediatric obesity problem is a big one, right? Actually now more than 14 million kids are affected with overweight and obesity worldwide. That's remarkable, 14 million children, right? Worse than that even is that the problem is growing. So in 1965, the census showed that 5% of US kids were obese. Now it's close to 19%. That's a dramatic rate of increase in terms of children who are suffering with this chronic illness. This, I think, is one of the most important statistics. It is estimated that 57%, that's greater than half of our children, by the time that they turn 19, will have obesity in 2050. That's not that far away from now. That's a remarkable statistic, and something we have to fix. Of course, COVID didn't help, but they weren't doing a lot of physical activity. They were eating junk food, right? And the COVID pandemic definitely increased the rates of obesity, not just in North America, but across the world. This is a really important concept. You know, Dr. Morali was talking about obesity in terms of kind of BMI and the specific numbers. In pediatrics, we really look at percentiles, and this is a really important concept unique to pediatric populations. So there are 3 main definitions to pay attention to. One is, so overweight is characterized as a BMI in kids over the 85th percentile. So you will have all seen the growth curves that we use in children to kind of map out, are they growing appropriately or not? So BMI is really essentially the same as that concept. So overweight is greater than or equal to the 85th percentile and less than the 95th percentile for age and sex. Obesity is classed as greater than or equal to 95th percentile. And then severe obesity, which is a different category that is clinically important, is greater than or equal to 120% of the 95th percentile. So just to conceptualize that a little bit, here is the growth curve that we look at, and we plot these when the kids come to see us in clinic. So if you look at the lines, really a kind of normal BMI is, Nafisa, if you wouldn't mind just pointing out on where the normal growth range is. And then see, this actually is from a patient of mine who plots so far above that we're classing now as a percentage of how obese you are. Indicates to you a little bit that how much of a problem this has become.
This is a normal BMI.
So anything below that would be classed as a normal BMI, right? Or really below the 85th percentile. And then above that is how far above the excess weight you are. So it's really becoming a huge problem. It's important to remember that within pediatric obesity, there are a number of risk factors. You know, we really think about this now as a chronic multifactorial disease, as opposed to the kids are just eating too much and lazy. You know, it's much more important than that and much more complicated than that. There are lots of factors, biopsychosocial kind of model of interplay of factors. I won't list all of these, you can see them here, but all of these play a really key role in the development of obesity in kids. So just to kind of really highlight this table, it doesn't project very well. The purpose really is to say, look at all of these risk factors that have been established as important in the development of obesity. This was taken from the most recent published guidelines from the American Academy of Pediatrics. I'd highlight a couple of things that are really, this not their own fault concept is really important, right? Because policy factors, neither the parents nor the kids have any control over, really, right? Outside of voting, they really have no control over those things. And how close they are to fast food and where fast food establishments decide to build their establishments is also, out of their control. But frankly, McDonald's and Burger King, they target their establishments to low socioeconomic neighborhoods for the exact reason that they know people with no money will buy the junk food because it's the cheapest option. And so these are things that are out of their control, right? Psychosocial stress, and we talk a lot in pediatrics about ACEs, adverse childhood experiences. These are important across the board of pediatric chronic disease, but especially so in obesity. And of course, there are genetic factors, and we're learning more and more about those and more about how important they are in the development of obesity. We won't spend too long on this slide here. This is kind of something that we all think about as obesity being a kind of a chronic multi-system disease, right? And Dr. Murali had a slide similar to this. Particularly in children, though, we also worry about the development of growth issues, right? So Dr. Mogri is going to talk about bone disease and things like that, but we really think about growth as being a big issue. The other thing is these kids are going to school, right? So self-esteem, depression, mental health-related issues, particularly now when adolescent and youth are undergoing really a mental health crisis, the obesity plays a really big and important part in that. I wanted to just highlight a couple of things. Let's have just a quick show of hands in the audience. Who has either seen, come across, talked to a family or a child with obesity or overweight? Right, so like most of us, I would say, right? And this will happen at some point. I mean, if the statistics follow the way we're expecting them to, this will happen at some point. So what are you going to ask them? How are you going to identify what are the issues leading to this child's obesity? Again, I won't, just for interest of time, won't go through all of these, and hopefully the slides can be shared with you all, but trying to really understand when you meet these families, what are the issues pertinent to that family? It's not just about you eat too much and you drink too much soda and you don't exercise. I mean, those are the principles, but within that, what are some specific things that you could target for the individual families? Let's move on to now kind of how do we manage obesity in pediatrics? Well, the laboratory evaluation is kind of the first step. Just to say, I mean, really when we think about screening for lipid abnormalities and fatty liver disease, blood pressure issues, really we're talking about are children overweight, obese, and kind of when do we have to think about all of those things. I would say if you're going to take away anything from this talk, it should be that really if there's any doubt and you're seeing a kid who's overweight or obese, just check their lipid panel, check their glycosylated hemoglobin, and check their liver enzymes, right? That will just give you kind of a broad strokes, what is the situation with this kid's metabolic function, right, in the setting of their overweight or obesity. In younger kids, we don't know as much about what those things mean, but in reality, I think as things play out, we're going to end up seeing more and more of these complications in younger age groups. And so I would advocate for just checking these things rather than not. Management approach we'll spend a little bit of time talking about. There's really 4 kind of key aspects to the management of pediatric obesity. Motivational interviewing, as you can see, it's a check mark for all age groups and all categories. And that's really important, and we'll talk about that, something that all of us can do in any clinical setting that we're in. Intensive health and behavior lifestyle treatment, we'll talk about that in a little bit more detail. Weight loss pharmacotherapy, Dr. Murali mentioned in some detail. I'll sort of talk about that specific to pediatrics. And then ultimately, like, when do we refer these kids to the more comprehensive programs? When do we send them to bariatric surgery? And we do. You might be surprised to hear. So let's start with motivational interviewing. This is something I really would encourage all of you to try to think about when you're seeing patients with, whether they're adults or kids with obesity or kind of chronic illness where they are having to do a lot of the management themselves. One is the sort of cornerstone of this is identifying what is the patient's own understanding of this disease and what is their own motivation to change it. The biggest problem that we have is these kids are obese, sometimes severely obese, but completely asymptomatic otherwise, right? And so convincing them that something is wrong is really, really difficult. And convincing their parents, oftentimes, you know, even in our own community, right? Like the more the kid eats, the healthier they are. Jammo, jammo dikra, haji jammo, right? Like this is so inherent for us. You know, and how many parents come to me, hamari jamaat ma ke my bachchu doesn't eat enough. Balle obese hoy ke je bhi hoy, my kid doesn't eat enough, right? We have this built-in cultural concept. And I think that's really important, is we need to identify, does this person even understand why this is a problem, and work on that to start with, right? But it's guiding the families to what they think they need to change and how they think they can change it. So me saying, Dikra, go and do a treadmill for 1 hour every day, maybe they don't have a treadmill, maybe they've never used a treadmill, maybe there's absolutely no time in the day for them to do 1 hour of treadmill, and maybe their parents don't even agree that they need those strategies. So we have to really identify what is the parent and the child willing to do, and how do we help them achieve those goals. And I will tell you that actually motivational interviewing has been studied very, very well in pediatrics and has been shown to work, actually. So people who employ really good motivational interviewing in the care of pediatric obese patients have made a difference in terms of reduction in BMI and weight loss. I would encourage all of you to download this free app. Hamnaj Kaila, I wish I would have included a QR code for this. I just worked on this. I didn't know this existed before this talk, honestly, so I'm also learning here. It's wonderful. It's a talk that in real time goes through how do you talk to this patient who's come to your office with obesity, right, or overweight, or they have some concerns with, you know, their lifestyle habits. This, you in real time can kind of click on the different responses and figure out what you would say in these different situations. It's really, really well done, and it's endorsed by the American Academy of Pediatrics. It's called Change Talk, freely available on Android and Apple. So now let's talk about the behavior and lifestyle treatment. The really key thing here is, look, we all talk about, right, you need to do more exercise, you need to eat better, all these things, but the key to intensive lifestyle management is, number one, is face-to-face time. So 26 hours or more of in-person, face-to-face connection with patients has been shown to be a key factor in the success of weight loss programs and weight management programs. So it's really, and it has to be consistent over a period of time. So a lot of the weight management programs that we have in children's hospitals and academic settings really live by this principle of we need to see these kids frequently to be able to empower them to change. Physical activity, right? It isn't just enough to say go on the treadmill, right? Make it engaging for them, make it fun. Group activities work really well in kids. And then for nutrition, right? Again, you can't just be like, don't drink soda, because like we all drink soda, right? It's not realistic. So instead of saying don't drink soda, say, okay, let's plan for the next 1 month, you're gonna cut down from 2 sodas a day to 1 soda a day. So just making it bite-sized for them so that they can make change gradually over time. Let's touch on the weight loss pharmacotherapy in pediatrics. Many of these medications Dr. Murali has already talked about. The things that we typically, so metformin is an off-label use in obesity, right? It's approved for the use of diabetes in kids, but many obesity centers will use metformin. It has been shown in a couple of really good randomized controlled trials to show reduction in BMI, but of course has to be combined with lifestyle measures also. There are some GI side effects with metformin, and in rare cases can cause a lactic acidosis, so we just kind of watch for those things. But in general, we used pretty widely. Orlistat, for reasons that Dr. Murali already described, we don't really use them in children, unless they're in diapers, which hopefully they're not needing that already. But generally speaking, very rarely used because of the horrible side effects. The GLP-1 agonists, the semaglutide, liraglutide, I think are going to be really the mainstay going forward of treatment of obesity in children. Nothing is approved technically, well, so semaglutide is approved in over 12-year-olds in obesity, but it's hard to get covered by insurance. We're working on that. There are more trials coming through. We hope that will change. One thing to remember is that with the GLP-1 agonists, you've got to make sure that they don't have any family history of multiple endocrine neoplasia, but just with some of the data that Dr. Murali had showed previously. So these drugs are coming soon, and we think will be widely available. For now, you know, we use the cutoff of 12 years because that's kind of what all of the clinical trial data shows. I suspect as time goes on, we may get them approved in younger age groups as well. Phentermine, topiramate, I won't go into the mechanism again for time, but they are both approved for use in children. Topiramate, really, we use them for anti-epileptics and headache treatment in children, but off-label in obesity as well. We use it because we know it's safe. We know our colleagues in neurology are using these medications, and so we're like, we'll get in on that action too. But it does really seem to work. And then particularly the combination of phentermine and topiramate is what has the strongest data in children for BMI reduction in the ages of 12 to 17. So Dr. Mogri and I were discussing, and Dr. Rafiq, that this is probably the most commonly used combination of drugs in pediatrics. Lisdexamfetamine is ADHD medications, right? And it's a stimulant known to cause appetite suppression and weight loss, can be used off-label. So many kids also have ADHD now, so we see this used in practice a lot, and does lead to pretty significant weight loss. When do we refer to bariatric surgery in this sort of more comprehensive programs? That's a whole talk in and of itself of kind of when and how does that work. But the recommendation from the most recent guidelines is not to mess around. If the kid is suffering and they're not making progress and their BMI is in the severe obesity range, we refer them. Bariatric surgery has been around in pediatrics for a long time, and it works. And there are several studies now, randomized control trials included, suggest that weight loss surgery is safe and effective in kids, gives a durable reduction in BMI, and there's significant amelioration of comorbidities. So the mainstay of bariatric surgery in pediatrics at the moment is in those kids that have evidence of metabolic dysfunction, right? So the kids with bad fatty liver disease, with hypertension, with diabetes. Typically, the Roux-en-Y, gastric bypass, and vertical sleeves are most commonly done in kids. And then the hepatologist in me, I know we're running out of time, sorry guys, but allow me a quick tangent into the world of fatty liver disease. Just to know that there's a whole new nomenclature for fatty liver disease. What used to be called really fatty liver disease is now steatotic liver disease, just make it more complicated for the patients, right? Instead of NAFLD, which used to be called non-alcoholic fatty liver disease, it's now called metabolic dysfunction-associated liver disease, so MASLD instead of NAFLD. And then NASH has become MASH, and there's an extra category that's been added for those who are not just obese with metabolic dysfunction, but also drink a lot of alcohol. What is NAFLD, MASLD now, and what's the problem in kids? Well, it's actually a huge problem in kids. 40% of obese children are now having some degree of steatotic liver disease. And that in some populations, so I will say Hispanic populations, and then also South Asians, tend to have a more severe phenotype with NAFLD, even at the lower BMI ranges. So it's becoming more and more of a problem, and it's actually the #1 indication for liver transplant in young adults. Think about that for a second, right? We're seeing obese kids, and the rate of that is growing. And then also now we're sending them into transplant at young adult ages. That's a really important problem to manage. There are genetic predispositions that I think we see more commonly in children. And then when do you suspect NAFLD? Well, or MASLD, any obese or overweight child that has persistent elevation of the ALT for more than 3 months. Management strategies are essentially everything we just talked about, as well as most likely the GLP-1 agonists. There are some trials looking at whether steatosis and fibrosis can reverse in pediatrics, and it looks like it probably can, and we're still waiting on some of the final data on that. And ultimately, bariatric surgery for the really difficult cases. And I think that's it. Shukran, everybody.
Bismillahirrahmanirrahim. Thank you all for coming here today. My topic are two. One is polycystic ovarian syndrome, and the second one is bone health. The reason I wanted to speak about polycystic ovarian syndrome is because a lot of our muminat behenos suffer from this disease pathology and fail to seek treatment, firstly because of lack of awareness, and secondly, I think there's a shame attached to the fact that they have higher male hormone levels compared to the female hormone levels. And so they fail to seek treatment, and I don't think they're aware of the fact that there are treatment modalities available for this disease. So a little bit about polycystic ovarian syndrome. It is actually the most common endocrinopathy that we see in reproductive health ages, and about 60% of them are obese. A lot of us think that PCOS is always associated with overweight condition, but now we're seeing this in a lot of normal weight young individuals, especially in the adolescents. The prevalence is 3 times more in the Asian population, and so of course it is important to us. And it is a combination of environmental and genetic factors, so it's not just their lifestyle, their eating habits, but also because they're Asians, they have a genetic predisposition to have this disease. So there are lots of criteria to diagnose PCOS, but the most common one used is the 2003 Rotterdam criteria, and it's actually a very simplified one to look at. If you see the 3 categories that you have to look at, one is chronic anovulation, clinical or biochemical hyperandrogenism, and polycystic ovarian syndrome on the ultrasound. If you have 2 out of these 3, you would be diagnosed with PCOS. And in adults, an AMH level can replace the ultrasound. In adolescent ages, you can actually have 20 follicles, so ultrasound is not the way to diagnose PCOS in adolescent girls. Ultrasound is only used in adults. So in adolescent age group, we just look at clinical biochemical signs and look for chronic anovulation. So how do you define anovulation? Now, once a girl hits menarche, they're known to have irregular periods. However, after the first year past their menarche age, their cycles should be between 21 to 45 days. So even frequent cycles, if they're having the periods every 2 weeks, that's abnormal. If they're having the periods after 1.5 months, that's 45 days, that's abnormal for 1 year after menarche. After 2 years, their cycles should really not be longer than 35 days. So the cycle length should be anywhere between 21 to 35 days. A lot of girls that I see come in with primary amenorrhea, means they don't get their cycles by the age of 15 years, and they are eventually diagnosed with PCOS. Or they've started breastfeeding around the age of 12, 13, but haven't had their periods for another 3 years. That workup can also show the diagnosis of PCOS. So how do you define clinical hyperandrogenism? So it's the Ferriman-Galway scale that we look at, and any score above 4 is classified as clinical hyperandrogenism. So all of these sites, when you look at the hair, if there are 2 sites with significant hair, that would be classified as hyperandrogenism. What about biochemical hyperandrogenism? So the 2 main tests that we do is total and free testosterone, and the most important thing is what assays are we using. So the LCMS is for the total testosterone, and equilibrium dialysis is what we do for the free testosterone. This is usually available at Quest, LabCorp, and all these major laboratories. If you do these tests and they're normal, but you have high clinical suspicion, then you can check the androstenedione. That's less likely to be elevated, but is sometimes elevated with normal total and free testosterone levels. You do want to rule out other uncommon disorders, which are congenital adrenal hyperplasia or an adrenal tumor. So we always do a baseline DHEAS and a 17-hydroxyprogesterone level to rule those other disease pathologies. So if you look at the JCM criteria on diagnosis of PCOS, if you see anyone with irregular cycles and clinical hyperandrogenism, that is actually classified as PCOS. You do not even need to do lab work. So it's a clinical diagnosis. However, we always do lab work to rule out other pathologies, like I mentioned, CAH or adrenal tumor. I do like to get a baseline testosterone and free testosterone level to see if we start treatment, how's the patient responding. If you don't see any clinical signs of hyperandrogenism, then you do go ahead and do the blood work to diagnosis. And like I said, if you're an adult, you do want to get ovarian ultrasound if one of these criteria are missing. So what's the pathophysiology? It's really the testosterone is coming from the ovaries. It's an intrinsic theca cell defect, and the LH effect on the theca cell is amplified if you have high insulin levels. So really it's the insulin resistance, that's the background, especially in the Asian population. And the insulin directly stimulates the androgen biosynthesis by the theca cells. But we do not check insulin levels because it's a very poor marker of insulin resistance. The level varies throughout the day. Fasting, post-meal insulin levels, there are no normal criteria. So I see a lot of, especially gynecologists and pediatricians check insulin levels. There is no more indication to use insulin level even if you have acanthosis or evidence of prediabetes or PCOS. So what's the role of genes? So it's the CYP17 gene, that's the gene encoding the enzymes which have the rate limiting effect on the androgen synthesis. And the dysregulation of this gene is seen in Asians, and that's why the Asians are more predisposed to polycystic ovarian syndrome. We are starting to see this also in normal weight individuals, and that's why it's not only with obesity or overweight. We see this in kids who are born really, really small. And the pathophysiology behind this is the rapidity of weight gain. So I have a lot of females with normal BMI coming with PCOS, but they were basically underweight before. And so the sudden weight gain has actually triggered insulin resistance in the background and caused you to have elevated testosterone levels. What are the complications of PCOS? So there's the metabolic syndrome, cardiovascular complication, type 2 diabetes. But it's interesting to note that obstructive sleep apnea is an independent risk factor with PCOS, and you are, even if you have normal BMI. If untreated, these patients can have unopposed estrogen synthesis, and that causes endometrial hyperplasia and ovarian and uterine cancers. Depression, anxiety, and eating disorders are other side effects that we see in complications. One of the most important one that we often fail to recognize is infertility. So a lot of young ladies come in with not being able to conceive, not being able to have children. You find out that they have irregular cycles, and they've had it ever since they started menarche, but no one addressed it in the adolescent age group, where you could have actually fixed the problem and they would have actually not had the fertility issues now that they're childbearing age. So number one, management. I tell all my PCOS patients, you do not need medications. If you can just lose 5 to 10 pounds, just that weight loss, even if you're obese or overweight or normal BMI, would fix the problem. The concept is really to improve the central obesity, so the waist-hip ratio is what you want to look at. The adolescent population, we recommend 1 hour of exercise daily, which is really the recommendation for the younger population. And in adults, we want them to do at least 300 minutes of moderate physical activities, which is 1 hour, 5 days a week. The treatment of choice that's FDA approved for PCOS is birth control with 30 micrograms of estradiol. A lot of my patients might not respond to that, and so we have to do the higher dose, which is 35 micrograms. The risk associated with that is DVT, thromboembolism, so you always have to counsel them to be not around smokers and make sure if they have any leg pain, chest pain, to seek healthcare. Metformin, I like to use that in a lot of my patients because it does have a weight benefit. I know long-term metformin doesn't help you lose weight, but in the first 6 months, if you combine it with lifestyle modification, you can have that 5 to 7 pound weight loss that you need to cure PCOS. So I really encourage my patients that when they initially want to do lifestyle modification, if they don't want to do birth control, which a lot of parents are hesitant because of the stigma with birth control, and birth control does cause some weight gain, so they do have to work harder to lose weight. Metformin is really the drug of choice with lifestyle modification. Like Batul said, the side effects of metformin, nausea, diarrhea, the things that I've seen work best is to prescribe the extended release form and to give it at bedtime. So right after dinner with food, start with a 500 milligram dose and then increase it to 1,000 a week later, build it up to 1,500, and then 2,000 is the goal adult dose. A lot of my young population, they get fixed with just 1,000 milligram of metformin. Another thing about metformin, risk of lactic acidosis associated when you're fasting, not keeping yourself hydrated. So I always tell my patients, if you're going to be fasting, you don't want to take this medication, any IV contrast. You want to make sure any sedation procedures, you don't want to take metformin the night before and a day after till they're starting to have a good oral diet. Anti-androgen therapies were used a lot previously, but honestly, I don't use much of them because of the side effects. Spironolactone causes hyperkalemia and you need to monitor electrolytes. Flutamide has liver toxicity. Cosmetic therapy like laser therapy is what I recommend for my young girls who have had normalization of testosterone, but they still have a lot of terminal hair because that terminal hair will not disappear. You can really get laser therapy and get rid of that hair, and if you continue the metformin lifestyle modification plus minus OCP, you should be in good shape. Ionositol is, a lot of people have asked me about that. It's a vitamin B complex. It's known to improve insulin signaling and decrease insulin resistance, so it has been shown to improve symptoms of PCOS. However, there's lack of quality evidence, so I'm not going to recommend that, but there's still work going on, and it's a pretty simple a medication to take, so I'm sure that in future it would have a role to play in polycystic ovarian syndrome. Now, I couldn't be here without talking about bone health because that's my field of interest. And so a little bit of obesity and vitamin D. So I know all of us like to pop in vitamin D, but just knowing that the prevalence is much higher in obese population, that would be a motivation for you to not gain weight. It's seen in 90% of our obese population to have low vitamin D level, and that's mostly because the vitamin D level gets sequestered in the fat cells and is not available in the blood for use. One of the other things you want to remember about vitamin D is because it's a fat-soluble vitamin, you always want to give it with meals. I have a lot of patients coming in taking 5,000 units of vitamin D, but they take it on empty stomach every day in the morning, and their levels are just not coming up. The best time to take it is after dinner, after lunch, whichever one they have fat in their diet. In the obese population, you need much higher supplements, and studies have shown that levels have improved after bariatric surgery because of release of those vitamin D stores from the fat cells. So even though for general population, the requirement of vitamin D by the International Osteoporosis Foundation is 800 international units, in obese population, the recommendation is high as 2,000, so almost 3 times. And nowadays, they're recommending BMI-based dosing. So there was a study in which all obese patients, BMI of about above 30, had low vitamin D levels. And when you looked at them, when you gave them 50,000 international unit of vitamin D and calcium for about 3 months, they had a normal vitamin D level of 34 and 33, pretty comparable at 3 months. After that, they were randomized into 2 groups. One group got 2,000 international units of vitamin D, and the other group got 125 international units based on the BMI. So when you saw them at 6 months, the one who got the fixed dosing had a decrease in vitamin D level, while the one with the BMI-based dosing were able to maintain a normal BMI vitamin D level. So this is the fixed dosing. They were unable to keep their levels up. And this is the BMI-based dosing, which pretty much kept the level where we needed to be above 30. What are the risk factors for low vitamin D? Dark skins, all of us Asians definitely have a dark skin. Decreased sun exposure, use of sunscreen. I know we send our kids outside to play and then we're like obsessed about, did you wear sunscreen? Guess what? They're not making any vitamin D. Lack of dietary intake, and breastfed infants, breast milk does not have vitamin D, and mothers who are not supplementing their kids who are breastfed will be vitamin D deficient. So how much sun do we need? That's a question that all of my patients ask me. So my kid plays outside, how much sun do you need? So you really need the sunshine between 10 a.m. and 3 p.m. How many of us are outside during that time? None, right? In spring, summer, or fall, forget winter. And you need 15 minutes of sunshine with hands, face, arms, and legs exposed. How many of us have that? And that's going to give you a dose of 1,000 units per day. Pretty much none of us, right? So we all need to make sure we're taking our supplements. In winter months, it's interesting to note that these areas at the latitude of 37 are not getting any vitamin D. So Dallas is one of the lucky places where you should be. We are actually getting vitamin D from sun even in the winter months because of our placement on the Earth. So what does vitamin D do? Vitamin D really, the thing that it does is obviously help strengthen our immune system. It's known to help us in cardiovascular disease and cancer. But really the main thing it's doing for us, for our bones, is absorb the calcium in your diet. Okay, so we all focus on how much vitamin D should we take? What's our vitamin D level? But no one talks about the calcium intake. And this is something that I really wanted to bring forward today because we all have kids. And we all have families. The NIH calcium requirement is based on weight, age, and sex. So the first 3 years we don't have a problem, right? All kids are drinking 18 ounces of milk under the age of 3. It's after the age 3 that we really need to make sure that our kids are getting at least 1,000, and when they hit puberty, 1,300 milligrams of calcium. And when you look at the peak bone mass, it's only in the first 2 decades of life that we're building our peak bone mass. So I know we concentrate a lot on, what are we doing for our older population, but really how much peak bone mass have you achieved is all the calcium and the vitamin D your kids are getting by the age of 30. and that's where we don't focus. So if you look at how much dairy should they be getting, 1 cup of milk gives you 300 milligram, a slice of cheese gives you the same, a cup of yogurt gives you about 200 milligram, and fruits and vegetables gives you about 100. So even if our kids are taking fruits and vegetables, that's just 100 milligram, we still need to give our kids at least 3 servings of dairy if they're prepubertal and 4 servings of dairy if they've hit puberty. Now, what does that come out to be? So when you look at my plate, we all talk about fruits, grains, protein, vegetables, but how many of us focus on how much dairy are we giving our kids with every meal? So really, for breakfast, all our kids should be taking a serving of milk. For lunch, you want to throw in a box of yogurt or string cheese. That's your second serving. When they come home from school, the snack, I know we all give them fruits, chips, cookies, whatever, but do we offer them milk? I don't know if everyone does. That's where your third serving is. And if you have a teenager who's in puberty, you really want to add another serving with dinner, put a mitto in the thal, or yogurt, or just have them drink another glass of milk at bedtime. And that's how they're going to pretty much get the 1,000 to 1,300 milligrams of calcium, which is what the vitamin D needs to absorb to get your bones stronger. So this case, this is one of the cases I really want to share with you guys because I see a lot of this. A 15-year-old boy with severe food allergies has been off all dairy after 1 year of age. His mom's put him on a multivitamin because she knows he's not taking enough dairy. He was diagnosed with Crohn's disease, received IV steroids for 1 to 2 weeks, followed by ileocecal resection. He complained of severe back pain. The spinal X-ray showed vertebral fractures at T8, 11, and 12. His vitamin D level was only 12, and the DEXA scan showed low bone density. I see a lot of these patients with food allergies, with milk protein intolerance. They take no dairy. They go to gastroenterologists. I recommend supplementation of calcium, but don't take it, and they come in with severe low bone density and fractures. And lastly, I would thank you all for coming here to Dallas, and make sure you go to the Dallas Stockyards and the water gardens. It's a really nice place to see, and hopefully that'll make you come back and see other places in Dallas. Thank you so much.
All right. Assalamu alaikum. How's everybody doing today? So I just wanted to continue on from Dr. Murali's speech and talk about weight management. So I'll be doing his was weight management 101, and mine will be weight management 102. So as an overview, I know Dr. Murali kind of discussed BMI and how it's not the greatest tool, and we'll kind of go over that as well a little bit. And also, from my standpoint, we'll talk about weight management approach as far as behavior, adjunctive medications, and I really want to touch base on some of the cases that we've had. So, show of hands. How many of you had parents who ate healthy, exercised regularly, and ate dinner early? Okay, 1, 2 people, great. So this was basically what we saw when we were growing up. We saw Auntie G over here in Asadi with a little extra skin hanging out on the sides. We saw Uncle with that central obesity. And this is what is the problem with, our culture in the South Asian population with regards to the central obesity, in that this is what increases our risk of cardiovascular disease, diabetes, and such and so forth. So again, I won't go over this that much, but the NHANES data that Dr. Murali kind of touched upon as well basically states that overweight people, there's 1 in 3 of us. So if you look to the left and look to the right, one of you are going to be overweight. Just don't look at yourself, and you should be okay. So again, the basal metabolic index with regards to the South Asians, in 2004, the WHO discussed this and actually decreased or made it more stringent as far as what the BMI should be. And again, Dr. Murali also talked about the Indian Health Ministry and how they even took it a step further and stated that anyone with a BMI of 25 is considered obese. So on the road to weight loss. Again, this is a talk on pediatric obesity and a growing crisis. So I'm discussing the growing crisis. as we transition from childhood obesity to adult obesity. There are studies that have shown that childhood obesity is linked to parental obesity. So a child that has one parent that's obese is 50% likely to be obese, and a child that has two parents that are obese are 80% likely to be obese. And children who are obese are more likely to be obese as adults. So we definitely want to treat childhood obesity as well as treating adult obesity in the same manner. So factors that play a role in obesity. We have the genes, as Dr. Morali again mentioned, the melanocortin 4 receptor, which diminished functions causes children to feel hungry, causing hyperphagia. We have environment, where they live geographically, what food availability is there, and also neighborhood walking ability, meaning how much people walk around. So for example, Houston, where I'm from, very few people walk, whereas in New York or in the Northeast, Boston, Chicago, there's more walking that's being done. Hence, the obesity is probably a little less in those areas. Also, stress and mental health. 20 to 60% of obese people suffer from mental health illnesses. And this is one of the things I will touch upon as we go through the slides in some of the cases. And sleep, as Dr. Morali talked about as well, how decreased sleep actually causes excess body weight. So again, what we know, that the need to treat adult obesity is paramount in helping our children. As we treat adult obesity, as we treat our patients, one of the things that we discuss is that as they make lifestyle changes, as they change the way they eat, as they choose better options for food, that translates to their children also eating better and picking better food choices as well. We talked about sleep as well as exercise. Exercise, approximately 150 to 200 minutes of moderate intensity exercise a day is recommended. However, there's new guidelines that even state that even minimal intensity exercise or activity, as Dr. Morali mentioned earlier, is important. So this actually is very important as far as longevity is concerned. We talked about weight regain, and one of the things that was found is that people who are not active are more likely to have weight regain. So activity is quite important. Eating a low-carb diet, high-protein diet, or higher protein diet, and eating at least 2 to 3 hours before sleep. We have this arbitrary number of 7 because on average, people sleep around 10:30. And then eating a low-calorie diet. And this is just an approximate range, but on average, 13 to 1,500 or 15 to 1,800 calorie diet will at least get them started on seeing those changes in their weight. So we discussed behavioral approach. And these are just a few things as far as drinking more water. We discuss activity, eating a healthy low glycemic index type of foods, and avoiding high glycemic index foods. And I just listed a few here. Some of the things that when I talk to my patients about, we talk about certain fruits that they may be eating, not realizing that is a higher glycemic index may be hindering their weight loss. Eating less processed foods, getting appropriate sleep, eat on smaller plates. One of the things that we also talk about with our patients is eating on salad plates as opposed to dinner plates, not going for seconds, eating slowly, and don't eat until fullness. So one of the things that I want to talk about and really focus on are the medications, the lipotropic injections, and hormone replacement. So we earlier heard about medications that are being used with regards to semaglutide, tirzepatide, which is being tested right now and should be coming out later this year, and phentermine, along with a slew of other medications. I'm going to take this a little different to a different approach as far as we do things where if they are unable to get certain medications, how can we still help our patients? Lipotropic injections, which are involved, that entail methionine, choline, vitamin B12, L-carnitine. These lipotropic injections, or these amino acids and essential nutrients, help and assist the breakdown of fats within the liver. They help in preserving muscle mass, as well as helping assist in burning stored fat. So these lipotropic injections are normally found in compounding pharmacies. And so we can go through compounding pharmacies that can assist us in getting these shots to help with the management of obesity or overweight. And then thirdly, hormone replacement therapy. Testosterone, on average, obese men have 30% less testosterone than those of normal weight. And that is because the fat cells have aromatase. And aromatase transfers testosterone into estrogen. And so less testosterone, more estrogen in our obese patients. So with regards to time, I'm just going to skip to some of our cases. So this is a lady that is a 53-year-old female. She was started on Mounjaro a year prior, where it was very easily accessible. You know, very simple, put in some questions and anyone can get Mounjaro or tirzepatide. She was on that for a few months. She was doing quite well. And then this year, she was unable to get tirzepatide. And so she was unable to get Wegovy or semaglutide. Her insurance did not cover that. And she did not want to take phentermine, as she has tried this in the past. And as Dr. Murali also mentioned, that the cost was quite exuberant. So one of the things that we went through is we went through a compounding pharmacy, and we compounded for her semaglutide with cyanocobalamin. And so this was much cheaper for her. We were able to get this, started her on this, and worked our way up to 2.4 milligrams weekly. The cost on average ranges anywhere from $150 to $300 per month. So one of the things that we can use are compounding pharmacies to assist our patients that are unable to get semaglutide or tirzepatide for that matter as well. So another case, and this is just to point out the different doses of semaglutide, or different formulations, and how it can be used. Semaglutide we think of is an injectable. However, in this particular patient, we were using it for his diabetes. It was Rybelsus, the oral formulation of semaglutide. Now, in this case, he lost some weight. He was doing really well. His A1C had come down. And the example that I want to really show is that semaglutide has two formulations, and that can be either given orally and injectable. The max dose of the oral formulation is equal to 1 milligram of the injectable formulation. So injectable is more potent and prevalent. And one of the things that we don't actually talk or haven't talked about as of yet is the mental health component when it is associated with weight management. And in both of these patients, the fact that they were able to continue their journey down and lose weight played a huge role on their positive outlook on life. They were extremely excited about the way they have made those transitions, and those transitions and the positive outlook was transformed onto other parts of their life with regards to making sure that they increase their activity, monitoring themselves for eating healthier, being more active in other parts of their life with regards to childhood, their children's activities, and just being more active. And so we don't really think about it or discuss the positive attitude and the positive outlook that can arise when one starts to achieve these small little goals with regards to their weight management. This is another example which we used testosterone as an adjunct. 44-year-old female with no medical issues. Her complaints were primarily fatigue, brain fog, depression, difficulty with sleep. We did some blood work on her and found that her testosterone was quite low. The normal range for testosterone in females is 5 to 50 on average, depending on the lab. However, we feel that the optimum level for women is around 100 to around 150. And so we started her on bioidentical hormones. And with that, she felt great. She lost 35 pounds over the course of 4 months. She was more active. She did not have the brain fog. She was feeling better. She was able to get better sleep, as well as just overall her improvement in her quality of life. And so this is another modality that we can use. Keep in mind, because we pelleted, it was a pellet formulation, testosterone, we also pelleted estrogen and recommended that she take progesterone given that she still had a uterus. Now my last example is this gentleman who, 65 years old, with multiple comorbidities, multiple medical issues, was on multiple medications for diabetes, hypertension, depression. And so we started him on phentermine initially. He was not able to tolerate it due to jitteriness, palpitations. And so then we also tested his testosterone and found that he was also hypotestosterone. And we approached him with bioidentical hormone replacement therapy. And after approximately a year, he comes into the office. We did coaching and behavioral therapy where we were seeing him approximately on a monthly to bi-monthly basis. And after 12 months, his A1C was improved. He has lost a tremendous amount of weight. He stopped taking half of his medications. He was off his amlodipine, he was off of his venlafaxine, and also stopped taking his metformin. And so it improved his quality of life. And going back to the positive outlook, this particular patient would come into the office, and after he had that confidence, he would come in and he would take his shirt off and show me his abs. He would show me that this is what he has done over the past 12 months. This is what he was able to do with the help of hormones and management. And so as far as physicians and helping our patients, we help them achieve a certain goal, but that translates into lots of other goals that they achieve along the way. And we sometimes don't realize that. So in conclusion, there are multiple reasons why one is overweight or obese. So we must look at multiple different ways of addressing it. Semaglutide right now is the hot topic, but it may not work for everybody. It may not be the only option that we have. And when we treat obesity, we're managing them holistically. We're trying to prevent their heart disease, diabetes, and we're promoting their mental health. And so, again, I want to thank you for your time and appreciation. I want to just mention that these slides were done by my daughter. I didn't realize how much I don't know anything about technology anymore. So I want to give a shout out to my daughter as well. Thank you.
Thank you to all the panelists. Any questions from the audience?
Ibrahim from Houston, a neurologist. So it was a really great talk from all you guys. I think highlighted a lot of different areas of importance and things. One question, my question is going to be from a neurological background. Sleep is so important, especially in pediatric populations. There's been numerous studies that even like 1 hour loss of sleep increases a lot of mood. ADHD increases it significantly, and also loss of stage 3 and REM sleep also increases insulin resistance and causes high blood pressure. The question I have is, in a general pediatric population, how many of these patients are you actually screening for sleep-related disorders that are leading to these other comorbidities?
Thank you, Bai. That's a really good question. In truth, probably not enough, right? I mean, I think the part of the problem that we have across the board of pediatrics, and I think there are many pediatricians in the audience that will agree, is that there's very little time to get anything done of real meaning when you're trying to bust through 20 patients with 10-minute well-child visits. I think that, in my experience, the pediatricians in our area do a pretty good job of at least screening basic kind of, or at least giving the anticipatory guidance of this is how much sleep you need. But then when they're getting up at 5 in the morning to catch the school bus, it's a little hard to enact. So to your point, I mean, I think we don't do enough of a good job of kind of really making sure that they're getting enough sleep. But I think societally it's hard also for certainly the older school-age kids to get that right amount of sleep. I mean, I try to get my kid to sleep at 7:30, but she fights me for a full hour, so.
I think from what your question is, I think it's very valid. I think what people are not screening is for sleep apnea. So the pediatricians are screening them for how many hours they're getting overnight, but what they're not asking is, are you restful when you wake up? Are you tired? Is your child snoring? In endocrinology, all kids overweight or obese, we always ask for risk of sleep apnea. It's almost like checking for diabetes, cholesterol, and liver dysfunction. We always screen, at least in endocrinology, for obstructive sleep apnea. But I think that's a very good point, because I don't think the pediatricians are asking that question.
I have a quick question for Dr. Rafiq. First off, my first question is, which medication do I need to use to have a body like yours? No, I'm kidding. Moving on. When will you be showing us your six-pack? No, my real question is, so all your patients, you talk about their mental health, right? A lot of them had depression, anxiety. So in your practice, in your weight management clinic, how often do you treat their mental health with medication?
So we definitely discuss mental health as part of the process. As far as treating mental health, it really just depends on what the situation is. For example, this gentleman, that the last case we were doing hormone replacement therapy for, we took him off medications. Sorry. So we took him off medications, or he actually weaned himself off medications. So it's not about looking at mental health, but more so looking at what the underlying cause could be. Yes, mental health and obesity are to a certain degree associated. There are people who have depression, and they tend to go to food as their source of comfort. We try to discuss goals, as been mentioned multiple times as well, small goals, and give them ways to not use food as their comfort zone. Sometimes we have to use medication, and we do, but also keep in mind some of these medications, these antidepressants, also cause weight gain at the same time. So it's a slippery slope as well, but we definitely, it is addressed. And I think what we do is we try to fight the small battles, and that leads them to better, more positive outcomes. And as those small goals are achieved, their mental health improves, their positive outlook improves. So I think it really is coming down to goal setting and expectations. Did that answer your question?
The last one, yes.
Okay. The first two we'll talk later.
And please introduce yourself, but you know, Munira Ben doesn't need much of an introduction.
My question for Dr. Mogri. By the way, I'm Dr. Munira Tutbai. I'm an OBGYN. I have a question and I have a statement. As a gynecologist, I agree with majority of what you had said, but I have a question about you mentioning OC pills of 30 and 35 as opposed to the 20. Is that what you wanted to say?
So the treatment recommendations are 30 to 35, and that's what suppresses the LH-FSH. I will be honest, I start with 20. A lot of my patients who initially start with dietary modification, metformin, if that's not bringing the testosterone level down for biochemical androgen elevation, I do start with 20 because of the side effects are much lesser. But the recommendations are that for PCOS, you need to start with 30 micrograms. That's what the recommendations are.
Well, in my practice, I've seen 20 works most of the time.
I agree. I agree with you, and I start with 20 myself. Most of the patients are so hesitant to start on OCPs, and the side effects for 30 and 35 are so high that starting with 20 is ideal. Again, given that the patients are willing to do the exercise and dietary modification, I think that is the number one.
Yes.
I start with 20 myself, but I've seen 60 to 70% of the patients on 20 eventually start having spotting, and then they need a higher dose if they're PCOS. So eventually the 30 micrograms is the recommended dose, I think, because they develop the spotting on the 20.
Then it's just a statement that you had said that gynecologists do insulin testing. Yes, that's true. And I think that is going to continue for some time because we do the insulin testing and we treat with metformin based on those values and then we repeat in 6 months.
So the problem with insulin levels are we don't have normal values. The fasting levels and post-meals levels, there are no normal values. And so the assay is not reliable. The insulin level assay, if you want to really look at insulin resistant, HOMA-IR is the way of looking for insulin resistance. That's the gold standard, the HOMA-IR. Insulin level is not recommended to test or even be a marker for treatment. Hemoglobin A1C and HOMA-IR are the gold standard.
So it's Mohammed Mogri, I'm from Dallas. I had a question and comment kind of mixed in. I think all these talks have been greatly informative, but one of the things as a pulmonologist we've seen is that in the last 20 years we've had 0 drugs developed for smoking cessation, but we've had a slew of drugs for asthma, COPD, all biologics. I can probably name 20 out of, and those are super expensive drugs, which is what seems to be the trend here as well. In terms of prevention, it seemed like you guys spoke about a multi-pronged approach, mental health, physical, nutrition. How do you bring this back to the Dawoodi Bohra community? I'll give you a quick example of the data from India is that 30% of people meet physical activity requirements, the Indian population, and women do terrible. So that's a general population, and when you look at women alone, they're less than 10%. So how do you get, as to your point, Batul, in engaging physical activity? I'm just using this as an example. I understand there's a lot more to weight loss and prevention. How do you engage a degree who's now going to get into adulthood and be able to sustain those physical activities of 30 minutes per day? And how do you avoid these late night meals that is part of our culture? And carb-heavy meals for dinner, which Dr. Murali spoke about, limit your carbs till 12 in the afternoon. So to everything that we've spoken about, how does this apply to us? What can we do as a community to make a difference? Because it's clear that we are also obviously jumped on the same bandwagon of childhood obesity and heading in the wrong direction.
That was an excellent question by Dr. Mogri.
Are we allowed to answer it? We have time?
If you speak like 10 miles an hour.
Okay. So, Molano SRM there has become increasingly a focus on our health, right? I mean, like just Jammanubi, like how things have changed as far as one mitas, one karas, from a community level, I think there's definitely a change in the way that we're thinking about food. And I think that helps because, on a personal level, in Chicago Jamaat, we really try to think about healthy eating and kind of how that translates to even how we eat. And how we are getting that food, what is on those plates. I think that we're really trying from a sort of Jamaat level to try to make that very clear to the kids. I think all of us should be doing that. Like I think all Jamaats across the world really should be trying from a madrasa level, right, to try to explain to these kids, ke I'm Jamo and I'm not Jamo, right? And I think that change is coming even from kind of Dawat perspective. The other thing that, just as a shameless plug for Chicago Jamaat, that my own husband is working very hard on trying to institute regular group physical activity. And I think that's something that we can do better for our kids also, that just as even part of madrasa, perhaps as part of the curriculum, we have sort of physical education built in where they can be doing things with their class, group-wise, maybe even gender-specific, right, where they're doing group activities. That has been shown time and time again in research to be the most engaging way for kids to do exercise when they're doing it together. So I think there's a lot that we still can do. We just got to talk about this more and keep talking about it so that all of the Jamaats kind of come to the same uniform level of basic, like this is how we eat healthily and this is what we expect from an exercise perspective.
And if I may add, I think bringing it back to our community is the essence of this conference. So I think Dr. Mogri has done a how to read a nutrition label madrasa activity, which could be shared in different Jamaats. But how do we impact behavioral change is the crux. And I think that is a challenge that sits in front of us like a mountain. I think one of the things Dr. Murali said is making them believe that they succeeded in something impacts behavioral change. But this kind of is a good lead to our next talk, which is clinical psychology in the pediatric population and parenting. But with a focus on not just physical and mental health. So I want to keep that thought alive. And again, try to bring it back to how do we impact our community. But thank you so much to the panelists. Thank you for being patient and for an engaging discussion. And I hope this continues for the rest of the day. Thank you.